Today we have Dr. Arul. He needs no introduction, but he is a renowned professor emeritus at St. John's University of London, with current roles at the University of Nicosia and Imperial College London. He has led the International Federation of Obstetrics and Gynecology, authored 38 books, and published nearly 325 articles. His contributions to medicine have earned him a Knight Bachelor by the late Queen in June 2009 for his services to medicine, the Sri Lanka Ranjana National Award in 2019, and Active Citizen Award in Cyprus in 2019. We have Dr. Sheela Mane here. She is a renowned DNB professor at KC General Hospital and senior consultant at OBGYN at Anugrah Nursing Home in Bangalore. As organizing secretary at AICOG and vice president of FOXY, she has significantly advanced women's healthcare. She chaired the FOXY Safe Motherhood Committee, earning awards for her contributions, including the Nehru Dara Hansotia Award. She's known as the PPH lady. She has conducted over 100 workshops on postpartum hemorrhage, demonstrating her dedication to maternal health. We have Dr. Alka Sehgal. She is the esteemed head of obstetrics and gynecology department at Government Medical College and Hospital, Chandigarh. She has significantly contributed to the field over 100 research publications. She is actively involved with various professional societies and academics. She is a pioneer member of the hepatitis vaccine in neonates and aneuploidies initiatives at GMCH. Her innovative contributions include developing plastic curtains as interveners during COVID-19 and providing training on the use of non-pneumatic anti-shock garments to medical colleges. We can take it ahead with Dr. Arul. He can start presenting, and then we can take forward the webinar.
Thank you very much for the kind introduction. So we are going to have 3 lectures today. I will start with fetal acoustic or vibroacoustic stimulation in obstetrics. And the purpose of the lecture is to give some science, but also for companies like Gynae to think what's the next step in research. And then we'll be followed by Professor Alka, who will talk about the impact of artificial intelligence on feto-maternal health. And Professor Sheela Mane will talk on prolonged deceleration and sinusoidal pattern. And then we'll have enough time for discussion. So I'll start with my lecture first, and then we will proceed with the others. So I hope you can see the screen. So my talk is going to be clinical use and concerns with vibroacoustic stimulus for assessment of fetal well-being. So vibroacoustic stimulus can be used to stimulate the baby to produce fetal movements or fetal heart rate accelerations, which indicates good health. But also there is some concern whether it is going to disturb the baby's sleep-wake pattern, whether it's going to create catecholamine release, whether it's going to cause hearing damage, and so on. So these are the things we are going to look at. So the FDA gave license to companies to produce this, what you see on the picture is a vibroacoustic stimulator, sometimes referred to as fetal vibroacoustic stimulation or fetal acoustic stimulation test, FAST. So the two terms are interrelated. VAS is vibroacoustic and FAST is fetal acoustic. But in terms of the baby hears the noise rather than the vibration. And it is the application of the vibratory sound on the maternal abdomen which produces the fetal movement and fetal heart rate accelerations, just like a startling reflex. Like I'm walking on the road and somebody toots a horn right behind me, my heart rate accelerates but settles down, the heart breaks. So that is the principle behind the assessment. So the objective of this talk is going to be to understand the use of vibroacoustic stimulation to elicit fetal movements and fetal heart rate acceleration as a test of fetal health in the antenatal and intrapartum period, and thereby reducing the incidence of fetal blood sampling in labor to check whether the baby is in good health or not. And also it has been used to facilitate external cephalic version. As you know, when you turn the baby, it comes to an oblique lie, and to negotiate the transverse diameter of the uterus is difficult, so you keep it an oblique and stimulate the baby kicks and turns itself to become cephalic. So that is also used. Now, the concerns about the use of vibroacoustic is because if you sound the vibroacoustic 2 centimeters from the ear, it's about 110 decibels, which means like staying close to a pneumatic drill or like a jet engine. And if it is exposed for a long time, then it is not good. So usually the stimulus is done only for 3 seconds or 5 seconds. But we have explored the possibility of cochlear damage because of the vibrations of the ciliary hair cells. If it is too much, can damage the cochlea. But there might be other mechanisms like shearing off of the basement membrane, which can give rise to auditory damage on the long term. So we have studied that. And immediate stress, as I mentioned, catecholamine surge, before and after measurements of the catecholamine on umbilical cord in utero. So it's in antenatal period. And disturbance of the fetal behavioral state, looking at the sleep-active cycles, and by computerized CTG, looking at disturbance to the autonomic nervous system. So if we look at the issues related to fetal heart rate accelerations, as you can see from this graph, number 3 says if the accelerations are present, not a single baby is acidotic. So this has been well proven in many studies, and this is just an example from Richard Beer's study. Now the question is whether the provoked accelerations compared to spontaneous accelerations, are they the same or not, is the question. So this has been studied by measuring the pH in labor. This is a classic example. Steve Clark from the Los Angeles University Hospital found whenever they did a fetal blood sampling, there is a fetal heart rate acceleration. As you could see here at the point of the arrow, the stimulus has been the fetal blood sampling and the heart rate accelerate. That means the pH can't be acidotic, it'll be quite normal. So that is a principle. So we followed his case reports in 1987 by doing a prospective study using an analysis tissue forceps. When the trace became abnormal with reduced variability or deceleration, we held that the head of the baby with the small ELISA tissue forceps, slight trauma, which is invasive. And if it produced accelerations, then there was not a single case of acidosis. But if it did not produce acceleration, 50% were in the acidotic or pre-acidotic range. So it's not a foolproof test. If it accelerates, it's a good sign, no acidosis. But if it doesn't accelerate, then same coming back to the reasoning of fetal blood sampling. Now in 2018, so 6 years from today's date, there was a study published by Deirdre Murphy from Ireland, from Rotunda Hospital. Instead of using an ELISA tissue forceps, they put the finger and stimulate the baby with continuous rubbing on the head with the finger. And they found that itself produced accelerations. And they did 298 procedures, and 84% had a normal scalp result. And there were a couple of cases with an abnormal scalp, but the Apgar scores and cord artery sample was normal. And that might be due to respiratory acidosis. Therefore, the baby responded to stimulation. So their conclusion was the study suggests fetal scalp stimulation with a finger has the potential to be a reliable alternative to fetal blood sampling. The findings require evaluation on a well-designed randomized controlled trial. So I think there is an ongoing trial when there is an abnormal trace. There, either you do a fetal blood sampling or scalp stimulation and see what the outcome for the babies would be. Now, the principle of stimulation has been there for a long time, like judging somebody who is fallen by the roadside to see whether they're opening the eyes spontaneously to sound. And if it is opening to the sound and responding, that person is not badly unconscious. So there can't be much hypoxia, hypoglycemia, or any other thing. And similarly, whether you can use the sound to produce movements, because you can't get the verbal response in utero. But if there's movements, that also means the baby cannot be in a bad shape. So originally it was started by Richard Paul from Los Angeles using an electronic larynx. So if you go to the ENT ward, you find these gadgets called electronic larynx, and that is kept in laryngectomized patients who have no vocal cord. by pressing and producing vibration, and the person can speak. So the same gadget can be used. The idea behind is the in utero sound level inside the uterus, because of the bowel movements of the mother, the aortic, everything is about 65 decibels. And you have to produce a sound which is more than 65 decibels for the baby to suddenly have a startling reaction. So based on that principle, using sound, Smith, again from Los Angeles, did a simple study of 64 women. And just when they were planning to do an FPS or an immediate section, they used a vibroacoustic stimulus and over the fetal vertex through the abdominal wall. And if there was reactive, that is 15 beats by 15 seconds acceleration, then they thought the FPS should be not necessary, because if it is not reactive, they would continue with the FPS. And they used different types of traces: late deceleration, variable decelerations, tachycardia, and the results and conclusion was very straightforward. No fetus that responded to the vibroacoustic stimulus was subsequently found to have a pH less than 725. And 5 fetuses who failed to respond did not respond to scalp puncture, and their pH was a little bit on the low side, but some had normal as well. So if it responds, it's a good. If it doesn't respond, then we don't know where we stand. That is the principle, which was with the scalp stimulation as well. This was studied a few years later by Polzin, again looking at 100 women in active labor, and he defined the accelerations 15 by 15, 10 by 10, and no acceleration, 3 groups. And what he found was interesting. If they had 15 by 15, there are 57 cases, their mean pH is much better, 7.18 to 7.39. Group 2 is also not bad if it is 10 by 10. But in group 3, there are no acceleration, then their pHs were much less, significantly less. So that was again indication that it's a good sign if you have acceleration. So his conclusion was, using a cutoff of pH 7.2, the overall ability to identify acidotic fetus using vibroacoustic stimulus was 90%. Now, there were other studies. This is Irion et al. I won't go through the details, but I'll read the conclusion as that's most important. And he said fetal heart acceleration induced by vibroacoustic stimulus is significantly associated with a normal scalp pH of 725. But he said VAS offers no advantage over observation of spontaneous fetal heart tracing. So if the baby has heart rate accelerations, you don't have to go and stimulate. And you cannot safely replace fetal blood sampling. That was a statement made because there are a couple of cases with a low pH which also responded with acceleration. So that was of some concern. So you see, of concern, 7 of the 31, scalp pH was less than 7 to appear to be associated with normal fetal heart response to vibroacoustic stimulation. So this was a worry. So even low pH babies have response to vibroacoustic. So we undertook a study from Singapore, Ingamasan and myself, looking at patients with bad abnormal traces. And there were 22 patients with no response. And there were 11 babies which are pre-acidotic or acidotic of these 22 babies. But there were 2 babies with low pHs, as you could see here, 2 fetuses, acidotic pH, but responded with fetal movement and acceleration. But both of them were respiratory acidosis. In other words, the pH was on the low side, but the base excess was normal. So in other words, we concluded that if there is a fetal heart rate accelerations of fetal movement, there is no ability or there's no chance of metabolic acidosis. Now, following all these studies, American College came out with the recommendation in 2005 that false positive rate of electronic fetal monitoring is high, and ancillary tests available to help ensure fetal heart rate is by producing a stimulation test, and all efforts should be made to elicit spontaneous acceleration. If it are not produced, then it has to be stimulated to produce the accelerations to reassure the baby's health. And they recommended that you can use one of 4 methods, either fetal scalp blood sampling, the stab itself, Alice's clamp scalp stimulation, vibroacoustic stimulation, or digital scalp stimulation. Each of these tests is a reliable method to exclude acidosis if accelerations are noted after stimulation. They continued by saying, because vibroacoustic stimulation, scalp stimulation digitally are less invasive than the other two methods, they are the preferred methods. But of the two, vibroacoustic is less invasive because you keep it on the abdomen, or a scalp stimulation, you have to do a vaginal examination to stimulate the baby's scalp. And when non-reassuring fetal heart racing persists and neither spontaneous nor stimulated accelerations are present, then a scalp blood sample might be necessary. And nowadays, it may not be available in tertiary hospitals as well. Now, the Royal College followed, or just before American College came out with this statement. All studies examined predicted pH level of 7.25. On all studies, the specificity was poor, but the sensitivity was poor with the specificity of 65 to 80%. So in other words, not all the babies responded, even if they have good pH. If they didn't respond, 50% are pre-acidotic, acidotic. So they also concluded to use it in practice, there must be a randomized control trial to assess the use of vibroacoustic to reduce the need for fetal blood sampling. So from there onwards, we started studying at the usefulness, and this was one of the first studies we did, evaluation of maternal perception of sound-provoked fetal movement. So these are high-risk mothers who came to the antenatal diagnostic center. And before we started the non-stress test or a CTG, we made a buzzing sound with a vibroacoustic stimulus. And if the mother felt the sound-provoked fetal movement, then we did the NST and we found it is always positive with accelerations and good variability. So much so, you don't have to do a CTG, just using a buzzing. Within 2 seconds, mother knows the baby is in good health. And then we followed it up with a number of other studies, looking at vibroacoustic and maternal perception of fetal movements and fetal heart rate acceleration at the same time, and looking at the fetal outcome. And we checked whether what the mother is saying is true by doing an ultrasound. When we use the vibroacoustic to see the mother is saying movements are present, and the baby also was seen to move. And we also used a handheld Doppler in the antenatal clinics and use the vibroacoustic. So we are listening with a Doppler, and then you buzz the vibroacoustic. And not only the mother feels the movements, but also on the digital Doppler, the heart rate acceleration is seen. So it doesn't take even 3 seconds to assess the baby is in good health if we had a vibroacoustic stimulus and a handheld Doppler. Now, we extended the use from the antepartum period to admission test. And as you could see from the last sentence here, the fetal acoustic stimulation might be of value in labor to give additional information about fetal well-being in patients previously screened by admission test. What happens when you do an admission test, 10% don't show activity, reactivity with accelerations. You have to wait for a longer time. Whereas if it doesn't show reactivity in 5 minutes, you can use the acoustic stimulator. It'll show acceleration, so you can cut short the test within a short time. And so much so you don't have to do a CTG. You can use the buzzer, and if the buzzer shows fetal movements, then that is good enough. We did a study again to compare what is the best admission test, whether it's a CTG alone or CTG with vibroacoustic stimulus, amniotic fluid index, umbilical artery Doppler, and we came to the conclusion the best admission CT test would be a CTG substituted with vibroacoustic stimulus if there were no accelerations. Now, the next use is about external cephalic version. This is a study which we showed that after 36 weeks, if we try to turn the baby, it gets stuck to negotiate the transverse axis of the uterus. And you can bring it up to that point and holding the pressure still, lifting the buttocks and pressing on the head, you make an acoustic stimulus. The baby kicks and turns, and it's more successful than just using terbutaline alone. So now we go on to safety concerns, and just to see, this is the normal pattern after 34 weeks. There's an active segment with accelerations and variability and a quiet epoch, then an accelerations. And this active quiet epoch in a baby is almost identical throughout labor. This is from the beginning to the end of the labor. So we wanted to study if we stimulate the baby either in the active phase or in the quiet epoch, whether this active sleep epoch period will be disturbed. And we didn't find that disturbance at all. For the initial 10 minutes, there was a disturbance where there's a tachycardia, but after that, it became quite normal. So this was the first study looking at fetal heart rate variability. Then we also wanted to study whether variability is disturbed by using a computerized CTG. And the first 10 minutes, there seems to be some increase in variability due to autonomic nervous system disturbance, but then it settles down very quickly. Now, John Spencer from Queen Charlotte's and myself, we got together and did a study to see. We looked at the active quiet epochs in the previous day before we used acoustic stimulation or the following day to see whether the active sleep episodes were similar on the day we stimulated compared to the previous day or the next day, and it was the same. So we found that the next complete rest activity cycle after vibroacoustic was not different in the duration to the complete cycle recorded in the previous day. So in other words, it has a momentary disturbance for 10 minutes, but otherwise it doesn't cause any problem. Now, what about catecholamine release? So when I was in lecture at Queen Charlotte's, we did this study. There were indicated cases for rhesus isoimmunization for fetal karyotyping. So we put the needle in the umbilical cord, take a sample for catecholamines. Then we use the buzzing sound to see whether the catecholamines will go up after 10 minutes or so. So we took a baseline sample for adrenaline, noradrenaline, and then repeated it 10 minutes later. We saw the fetal movements and increase in fetal heart rate, but we didn't see any change in the catecholamine level. So the initial disturbance, which comes immediately with an acceleration and increased variability, is due to the sympathetic, parasympathetic activity and not due to catecholamine release, which is like a stress reaction. And we also wanted to find out whether it's going to cause damage to the baby. So we used this hydrophone, which is used for spying, like in water pots and so on. We introduced this hydrophone. It's a very small object, and it can be introduced out of rupture of membranes for those who needed indication. And we recorded the sound levels. And the background noise with the hydrophone was 63 to 80 decibels. So the bowel sounds and the aortic vessel sounds can be very high. And we used different sound pressure levels of pushing the acoustic stimulus deep into the abdomen or very superficially, and it created 116 to 129 decibels. So this is of some concern because these are large, very high pitched noise, and this might cause more damage to the cochlear cells. So we wanted to study this more in detail. So we wanted to do that by doing in utero sound levels when is applied to the maternal abdomen, and also when it was kept about 2 centimeters from the abdominal wall to see whether the sounds are transmitted in touching the abdomen and 2 centimeters above. And we showed that the sound levels vary depending on the frequency of the sound created by using a box in between the acoustic stimulator and the machine which generated the different frequency. We stimulated at 55, 110, and 220 hertz. And the sound levels is increased with increased frequency. And this is when the acoustic stimulator is touching the abdomen, and this is when it is separated 2 centimeters from the air. So the sound stimulus goes through. In other words, the acoustic part is the one which disturbs the baby, not the vibratory part. So people have tried electric toothbrush and so on, but it doesn't work. So it has to be a sound, and you got to produce the sound somewhere between above 65 decibels, which is the background noise, ideally by 85 to 90 decibels. And that's what we found. Now, in terms of the cochlear damage, there are many mechanisms when the sound level is high. The middle ear with the incus, stapes, and malleus tends to vibrate more and to damp down the signs if it is very much lower. But if it still goes through, the pressure goes to the inner cell. And as you could see, the cochlear apparatus here, which is more to do with sound perception, and there are ciliary hair cells which can get agitated and get dropped off. So this is how the system works. From the middle ear, the sound is transmitted and it goes through the cochlear apparatus, and it is sensed by the nerves by the auditory nerve, and then we receive the sound as we hear it now. Whether the ciliary hair cells, if it gets disturbed too much, then it can cause ciliary damage. So we studied what is known as impedance, and impedance in water is much less compared to in air. For example, in the sound travels faster in solid medium. Those days, as children, we used to keep the head on the railway track to see when the trains are appearing, because even before the sound comes, it is transmitted through solid medium. But the vibration of the particles in the solid medium is very little. So one particle bangs a little bit, another one. But in the air, the vibration is much greater. So the sound speed is different from the acoustic impedance. Acoustic impedance is measured in riles, is much higher, whereas in water it's much less vibration of the hair cells. So we concluded, based on the studies, that mean intrauterine pressure is 90.7 decibels. It's like correspond to cilia vibration caused by a pneumatic drill at 7-meter distance. So it's not 7 meters is quite a distance. And we also concluded, starting at the eardrum, the vibration due to fluid sound movement is 1 in 4,000 of that in air for the same sound pressure. This means that amniotic fluid in the sound intensity is 36 decibels less than it would be in the air for the same sound pressure. So we came to a number of conclusions, but so if the hydrophone gave an indication 90 decibels after having been calibrated, the cilia would perceive a vibratory response of 34 decibels in air. It's a very slow movement rather than a rapid movement of the cilia when it has amniotic fluid inside and that's filled with cochlear fluid inside. So the cilia excursion produced by the vibroacoustic stimulator used in the study would, on this basis, correspond to that of normal conversation at 1 meter and would below the constitution as a hazard. Now, we were not satisfied just by giving the theoretical arguments of impedance. We want to actually test the baby. So we had 465 babies who had sound stimulation. We called them at 4 years of age and tested their frequency, the sound perception, at 25 decibels at 1,000 hertz and 4,000 hertz. And there were some children who failed the test, and as you could see here, 12 of them had impacted wax, and there's 15 of them had middle ear effusion because of middle ear infection, and they had to be treated. Only one baby had congenital sloping hearing loss. The others all, after treatment, clearing the wax and treating the otitis media, were able to hear. This is how it is done. This is a man, but as a child was kept with the mother inside and asked to push a button when they hear the sound. And if it doesn't hear the sound, then we subjected them to tympanometry, producing a wave, and the tympanometer will tell you with the movements whether tympanum is moving up or down. If it is not moving, that means there's fluid inside or wax inside, and we could look at that separately. So what does Cochrane say about all this? They say it's a good thing which has to be tested, but unfortunately there is no randomized control evidence for use of vibroacoustic stimulation in clinical practice. And there's no evidence contradicting its use, because we are shown by all the safety studies I have mentioned to you. There are no concerns, but somebody has to do an analysis of testing half the test. For antenatally, for example, instead of doing non-stress test in 1,000 women, 500 are non-stress test, 500 has only vibroacoustic stimulation, and then see what the outcome is. And the ideal candidates might be those who are coming for induction of labor, so you don't have to wait. The results will be known about the outcome within a short time. In labor, you can do that to see whether it reduces the cesarean section rate by producing the accelerations. Then you don't have to rush in and do a cesarean section. So you can take 1,000 cases and 500, you do the normal management, and by pulling a random number, and the other 500 cases, you use a VAS, and if it doesn't respond, you might want to do a section, but if it responds, you can leave the mother and baby alone. So that is something which has to be done. So in conclusion, I can say VAS stimulated fetal movements and fetal heart acceleration suggest no hypoxic fetus in the antenatal or intrapartum period. That means if they have accelerations and fetal movement. It reduces the fetal blood sampling in labor and facilitates external cephalic version. And we found there are no concerns about cochlear damage or ciliary damage, auditory damage, long-term effect, stress to the fetus, or disturbance of the behavioral cycle. Now, there was a study which was proposed to the FDA using a mobile phone application. So there was some application to produce the sound put on the mobile phone. So instead of carrying a separate instrument, the doctor could switch the mobile phone, switch the applicator, and apply the stimulus and look for acoustic stimulus accelerations or not. There might be a patent on that, I don't know. If Gynae is interested, they have to look into that. So you don't have to carry an extra instrument, but you can use the mobile phone to stimulate the outcome. And I will leave the impression that the talk is based on 22 papers on the subject done by us, by our group. And thank you for your kind listening. And if there are any questions, I'll be happy to answer. Thank you very much. And maybe we can proceed with Professor Alka Sehgal's lecture, and then with Sheela Mane's lecture, and then we can ask for questions and answers at the end. Thank you.
Dr. Arul, can I just give a compliment?
Sure, sure.
I'm a postgraduate of PGI Chandigarh, and Dr. Salla Gopalan used to be our head of the department, and we were categorically told to read your books. We did, but it's the first time that I have learned that you are so clear about the basic anatomy and physiology that it is just worth listening to you. I missed most of the lecture because there was some complication with these opening up the Zoom, but I am fascinated by your talk.
Thank you. Gynae will have this recorded, so I'm sure they will share it with you.
Yeah, I did. I took the last lecture also from the record because I could not attend.
Thank you.
But it is just too fascinating to know that somebody could, as an obstetrician, knows in depth so much about the research topic one is talking about.
Yes, there's more research to be done in this area, so I thought might be.
I know.
Youngsters.
I know. We actually used to, because we didn't have a scalp pH in India, so we used to try, with fingers, with 2 fingers, stimulation, and of course look for acceleration. But the same thing. I mean, if there is an acceleration, it was very comforting. But if the acceleration is not there, you just wheel in the patient in India to the operation theater. That's how in India, even in an academic institute, things work.
Yeah.
Because you have so many limitations in our country.
Yeah, Steve Smith used to do stimulation. If it doesn't respond, he waits for a couple of minutes, does the second one and third one. If the third also didn't respond, then he thought it was reasonable to intervene. So he didn't stop with 1, he did 3.
I thought we were never too independent to take such decisions, because you were always answerable for what you did and what you did not do in the morning to your teachers, so or your unit seniors. So the safer thing one would find, is to at least give a healthy baby to the mother in whichever minutes. Yes. So I'm sure Dr. Sheela is wanting to give you the compliment too. Over to you, Dr. Sheela.
Sheela is muted.
Yeah.
Yeah, the same feeling here, I mean, the way sir explains, and we always think that we don't have the scalp blood pH, thank you, sir, facility. And I think, as you said, even though we are in institutions, sir, I think these basic things are still need to be taught to all the residents and those who are managing the patients in labor. Because, the idea is it's a simple thing, but I think, as Madam said in institute, if you have more number of patients and they are overworked and then so many things are missed. And sometimes add something better. But definitely I've gained so much of insight now, and I think I can really apply and tell my residents also, and to myself also, that how to assess and go ahead. So thank you for that excellent.
Thank you very
After
much.
listening to Dr. Arul, you feel like doing your residency again.
Yes.
With somebody who's so clear about the concepts, you have a safety of margin with that person. So you would blindly be able to follow, certain things. I really wish, Dr. Arul, you were in our life earlier, physically. And books you were, but physically it's been very fascinating. And that's why I intend to meet you in Bangalore positively.
Thank you.
So from that aspect, I just wanted to share with you my last thesis. In fact, we did our last thesis based on this only. We wanted to do the correlation between the CTG and the neonatal outcomes.
Yeah.
And you would be surprised that 95% of the times, irrespective of what the CTG findings were, because as a thesis, we could not have interfered with the protocol being followed by any unit. But the cesarean section rate was 95%. So, in fact, the comment which I gave when I sent the paper for publication was that probably in India, CTG is being used not for preventing a cesarean section, but to look for an indication for cesarean section. And obviously, the paper never got accepted. On that comment, I was asked to withdraw it. I said, no, I'm not going to withdraw it, whether you publish it or not, because we really need to look into our, CTG, how to read CTG, and how to be able to, withhold our hands from doing a cesarean section. And that is where, the level of understanding of your from physiology and then your further perspectives is very important for the residents. So I hope we'll have you physically in one of the classes in Chandigarh. I'll try to see that.
Thank you. So Janitri wants us to move for the next lecture. So I think Professor Alka, you're going to give the lecture next.
Okay. Yes, I'm supposed to give that. And of course, I have that sharing. I was struggling all this time, for the sign of sharing. Now I have it. So I'll be sharing my lecture now.
Thank you.
Yeah, thank you. Roshni, are you there?
Yes, we are there, ma'am. You want us to share the screen?
I think because I can see my desktop, I can see my lecture, but I'm not able to share. There is open system preferences.
No problem, ma'am. We will do it. No problem.
Okay.
Okay, it has come up now.
Okay.
I can see your slides, yeah.
Okay. Good afternoon, everyone.
Good afternoon.
I'm finding that it's very difficult to talk after a lecture being given by Dr. Arul, especially because Whereas Dr. Arul is the master of what he talked on, I don't know anything about the topic which I'm going to talk on. And in fact, I chose this topic because I don't know anything. And I always feel when you want to, when you are giving a lecture on something which you don't know, you try to do justice to it as much. So I did try, and I hope rest of the people or the audience is as ignorant on this topic as I am, because only then I can do some justice to it. Can I have the next slide? Yeah. So the animation is not working, and unfortunately, because of animation not working on their side, the slides may look a little crowded, and you will pardon me for that. Now, can we go back to the first slide? Yeah. So what was our traditional learning and working style was that we gathered the knowledge from books, teachers, clinical practices, conferences, journals, or any other source for that matter, and collected it in our brains. That's true for every healthcare provider. And hence there is a lot of individual discrepancies in practice, not only in clinical practice of every day, but also in how we updated our knowledge and practices subsequently. So classically, our clinical managements were based on making a provisional or a differential diagnosis based on the clinical features, signs, symptoms, present, past, family history. And we would actually supplement, we still do supplement them with examination and then correlate with some basic investigations, go on to non-specific, and then later on to specific investigations. Then we follow up for the response of the treatment given, and then individualize the patient's further management accordingly. Now, each of the above component has a subjectiveness and dependence on the knowledge, intelligence, exposure, experience, devotion, etc., which varies from doctor to doctor. Now, with observations, studies, projects, thesis, multicentric studies, etc., the application of the statistics came into being, and the data was, the statistics were applied to various things, maybe clinical features, investigations, diagnosis, etc., and we refined our healthcare accordingly. Then came the era of clinical critical reviews, meta-analysis, and evidence-based learnings, which requires each one of us to, mandatorily update our current practices. Post-COVID, we have seen a surge of online learning across borders, and now abundant information just a click away on the mobile phones, both for the seekers and service providers, with its advantages and disadvantages. Can I have the next slide, please? Now, artificial intelligence as an advanced technology is in use for enhancing the diagnostic accuracy in the clinical setups in some specialties, and its use is steadily increasing. Beyond, of course, diagnosis to encompass various other roles. For example, in our field also, the application is there, how we are going to see that it's already in practice. But let us just learn few terms which are important from learning or understanding what AI is. The terms are machine learning, natural language processing, computer vision, and artificial intelligence. Can I have the next slide? Now, machine learning is a subfield of artificial intelligence, which is defined as a capability of the machine to initiate intelligent human behavior and to analyze vast data sets to predict outcomes of the field under study, including the healthcare, and would be most relevant to us when we talk about feto-maternal health. Now, contrary to the traditional statistics, the ML corresponds to a wide variety of methods that use in addition to statistics, mathematics, and computational science to learn from multivariate data about a particular subject. And we would be restricting ourselves to feto-maternal health. Now, a large data is collected and their outputs are fed and run on a computer to create a program that is then used for the traditional programming. Now, MI uses some neutral networks akin to the neurons in the human brain, where for a given input, multiple levels of representations of data can be extracted to solve a problem. Now, contrary to the parametric models which are used to which are interpretable, require less data, are fast, and don't perform too well on the complex problems, we were dependent on these in the past. MI contrarily uses the parametric models. Can I have the next slides? What do we mean by non-parametric models is that for these models, their number of parameters are not fixed. And when constructing a function to map the input and output, the model never assumes any function. So resultantly, the parametric models can learn any form of the function to map the input and output. And this flexibility permits better models, shows as no assumptions are being made, and there are a variety of these. They have the advantage of being more accurate in prediction and can form and solve any complex functions and require no assumptions about data. However, the disadvantage is that it requires very huge data, and that is where the CTG monitoring like equipments prepared being by Gen3 may be very, very useful, because we would be gathering the data and then this data can be fed and used by AI. Next slide, please. Now, computing the machinery and intelligence is not a new issue. It has been published as way back in 1950, and games like chess and Go were being played. And these were not easy. They required strategy, foresight, and logics, all of which are qualities which are typically attributed to human intelligence. So artificial intelligence is no less. Can I have the next slide? Now, the components of AI, the natural language processing, interprets the medical text and the patient records to assist in diagnosis and treatment decisions, whereas computer vision enables the analysis of medical images for early detections of variants, and hence making the diagnosis easy and detecting the complications easier. It also empowers systems to identify patterns in data and subsequently make predictions or assessment based on these patterns. So this CV helps draw conclusions of a subject under study, and fetomaternal health or complication is just one of them. Artificial neural networking, the algorithms can be processed and analyze large volumes of data, making it possible to identify very subtle patterns and deviations that might go unnoticed through the traditional medical tests. Now, ANN models identify patterns in the complex medical data and in risk assessment and intervention planning. The functions of the learning can be descriptive, that means using the data to explain what happened, predictive as to what will happen, and prescriptive to suggest what action can be taken. Next slide, please. In nutshell, instead of one human brain analyzing the data, the outcomes collected by thousands of human minds on thousands of occasions for provisional diagnosis, investigations, ultrasound pictures, etc. from the records are fed into the machine, and the programmer runs on a computer to produce an output. And this is called as program development by the computer. And the programmers will choose a machine learning model to use supplied data and let the computer model train itself to find patterns which help in making the predictions. These could be supervised or unsupervised. The advantage of AI programming is possibility of adding more parameters at a later date to develop more models or improvise the existing models. Now, the various models are then validated, compared, and the constant refinement is hence possible. Next slide, please. So this is just in a nutshell what I have made a statement that the data records are made, then ML, NLP, ANN, and CV, what we have talked about, is all contributing for the validation of the data and interpretation and decision and recommendations. Now, this graph shows how many publications have been made in the year from the year 2000 to 2023. So you would see that somewhere near the COVID, people probably had time, or we started becoming more dependent on the use of AI, and therefore started looking for it. And you can see that working on AI, the publications have increased so many tremendously over the last couple of years. Next slide, please. What is the current status of feto-maternal health? For an healthy outcome from conception to delivery, both mother and fetuses are dependent on multiple factors, and the quality varies tremendously from the level of healthcare. Now, for prevention or intervention, one needs early detection of any abnormality or complications that significantly influence the course of pregnancy and health of the pair, like preeclampsia, gestational diabetes, fetal growth restriction, etc. Whereas failure to identify or timely manage some other factors can lead to adverse outcomes such as preterm birth, stillbirth, maternal mortality, or long-term health issues with the newborn. Now, apart from these high risks, even low-risk pregnancies are prone to some acute complications. Yet, despite our continuous evolution of existing antenatal care via clinical examinations, supplemented with investigations, sonograms, many challenges and early detections of many complications, specifically keeping the constraint of resources, limited access to the specialized care professionals and diagnostic equipment, hinders timely and comprehensive assessment. Next slide, please. So what is the focus of AI? Now, as interpreting complex medical data and predicting potential risks accurately by conventional approaches are far from satisfactory. So the focus of many of these AI studies is on identifications of the limitations of the current methods and integrating it with AI to upgrade and advance the algorithms, particularly to address and focus on challenges in early detection. Now, AI-assisted approaches are expected to leverage advanced algorithms and predictive models to enhance decision-making, optimize healthcare delivery, especially in developing nations, and ultimately improve the patient outcome in feto-maternal health. But who shall take the blame for medical-legal implications if the diagnosis goes wrong is a big query. Next slide, please. Now, this I just wanted to show that of the healthcare systems, of the maternal, these two are the areas where AI is very developed now. One is for sensors for looking for high blood pressure, preterm birth, seizures, diabetes, abnormal heart rates, high-risk pregnancies, stillbirths, whereas the algorithms have been developed for picking up congenital malformations, route of delivery, picking up aneuploidies, fetal health, ectopic pregnancies, making guess of the fetal weight, in vitro fertilization outcomes, and Braxton Hicks, etc. I will not limit myself to this and not go to the infant part. Next slide, please. Next slide, please. Now, I will also not go into the details of this slide, but I just wanted to show that these are high blood pressure, preterm birth, seizures, diabetes, abnormal heart rates, high-risk pregnancies, stillbirth detection. These are the places where sensors have been developed, and each article in itself is a huge article to see how and how much it is in use, experimental, what are their limitations, and how improvisations are being planned. Next slide, please. Now, this is in a publication on theoretical exploration of artificial intelligence and its impact on the feto-maternal health from conception to delivery, published in International Journal of Women's Health very recently in 2024. It defined AI as machines that can recognize a visual scene, understand a text written in the natural language, or perform an action in the physical world. This article explored the scope of facilitation by AI in early pregnancy detection, genetic screening, continuous monitoring of maternal health parameters, providing real-time alerts for deviations, enhancing the ultrasound imaging for early detection of fetal abnormalities, and contributing to informed decision-making. However, the literature on established practical applications for clinical use are skeptical. Next slide. Now, I just wanted to inform that way back in 2015, me, my husband, and one of his students had just written a small article on automated text messages as reminders to promote good health. And I was surprised how it was picked up to be used by AI for, improving the health. This was just an idea at that time. I was not even aware of anything like AI exists. And for my last thesis, we initiated a study which was based on another study which was quoting the smart scope to be an accurate digital visual inspection with the VIA test for evaluating the cervical health. They stated that it was extremely good, and therefore with the advantage that the results are not subjective and it is user friendly and can be performed by a minimally trained nurse to take an immediate decision regarding patient management in a minimalistic settings like a PHC. We took up this thesis. We have just completed this thesis, but unfortunately we did not find AI much of help. In fact, the results were inferior to what results were given to us by the resident who was working on these cases. Next slide, please. Next slide, please. Yeah. So automated assessment of digital images of uterine cervix captured by using a device. This was the publication on which our thesis was based. They made statements, very high statements compared to the colposcopy. They said the smart scope was much, much better. However, as I stated, our thesis did not find it so, but this is just to show you the picture that there are definitely an advantage. This is handy, very handy smart scope. The images are taken right close to the cervix because you can insert this part into the vagina, and these images are then transferred for evaluation by AI. So this would be anyway better than not doing anything in the peripheral setups, because this could be actually done by anyone. Next slide, please. Now, artificial intelligence in imaging in the first trimester of pregnancy, a systemic review of 27 studies was published very recently in March 2024. Can I have the, we know that the embryonic stage is very important for evaluation of the impact of periconceptional events, health of fetus, and prediction for long-term prognosis. And because this part is amenable to ultrasound evaluation, which can also store the data and very accessible for use by AI. So therefore, a lot of work has been done in this part of the pregnancy. Next slide. So segmentation studies, you can go very fast in this thing. Segmentations has been done. Many studies have been done where placenta has been segmented, GSAC have been segmented, or CRL, or fetus cerebral cortex. One parameter, more than one parameters, or multiple segmentations of various areas, including the nuchal translucency detection for aneuploidies and abnormal placental images textures to predict hypertensive disorders of pregnancies. These have all been, you can say, attempted. Next slide, please. However, when it comes to the conclusion of the review, it stated that despite the exponential increase in the AI-related research, it is still in the developmental stage in first trimester pregnancy imaging and has yet to taste the transition from research to clinical implementation. It might facilitate using basic ultrasound availabilities to non-expert sonographers. So once the validity is being made, it is in clinical practice, then it will be very good because it can be done by even non-expert sonographers. However, the liability in case of misdiagnosis again remains a concern. So just this give me a thought. I wondered if we have the data of the first trimester bleeding, its presence, size of subchorionic hematoma, and follow-up outcomes. This could probably be made available to the AI and correlate with pregnancy complications and outcomes like risk of abortion, placenta previa, accidental hemorrhage, placental insufficiency, etc. So this can definitely be planned. Next slide, please. Similarly, another study was published way back in 2015 on usability and feasibility of PIRES on the move and M-Health apparatus for detection of the preeclampsia and management, in fact. This was extremely, I went through the whole study. It is really, really, impressive that something on the mobile is possible, and the nurses can and the midwives can be trained on it. Now, preeclampsia, and this is PIRES, is a preeclampsia integrated estimate of risk. On the move is POTM, which is a low cost, easy to use mobile health platform, which was created to aid health workers in making decisions around the management of hypertensive pregnancy, pregnant women. Now, this itself was based on two previously successful innovations into M-health apparatus, which is called as mobile health apparatus. And earlier, the studies were on mini-PIRES risk assessment model. And as you see, this risk assessment model was made on all demographic factors which are available to us in the history itself and on the clinical examination, symptoms, and of course, anybody who's trained into picking up this could use it. This was in addition used with the phone oximeter, and PO2 levels when combined with this mini PIRES risk assessment was used together to see what is the probability of the development of preeclampsia in the patient, and hence the management on the phone was conveyed to these peripheral areas for managing the patients at base. Next slide, please. Perinatal health predictors using AI also has been reviewed very, very recently in 2021. And it stated that in the long-term implications of severe maternal morbidity, this study is focused only on the postpartum phase. So in association with preeclampsia, with increased risk of cardiovascular disease, we talk about it, but now with AI, it is going to be possible for us to follow up more easily. Similarly, for the infants, increased risk of fetal death, preterm births, low birth weights can be predicted from some of the factors which can be fed in the algorithms prepared by the AI. Now, the review looks into the use of AI for postpartum care, including sepsis, follow-up of GDM patients, preeclampsia, postpartum psychiatric evaluation, etc. Next slide, please. Now, review on the use of AI in fetal heart monitoring. We have had so many lectures, so I will not go into the first two lines, except that the limitations have been quoted by the review, which are very mindful. It states that AI algorithms can analyze fetal monitoring and provide insights into the fetal health. There may be instances of suboptimal interpretations. Now, variations due to fetal movements, maternal physiology, or equipment calibration could affect the reliability of AI-generated assessments. Furthermore, AI algorithm trained on specific data sets may lack generalizability when applied to diverse patient populations or clinical settings because of the variation in the demographic characteristics, medical histories, or healthcare practices among the subjects, leading to suboptimal performance in the real world scenarios. This is highlighted because we are now focusing on AI-based CTG monitoring. Next slide, please. Similar studies have been, focusing on the deep learning methods to improve the pregnancy outcomes. And there were 127 distinct studies using AI and ML in healthcare, enabling the deep phenotyping. Now, the study of the phenotyping only requires knowledge of the spectrum of phenotypes associated with the disease entity, and deep phenotyping disease is a step towards precision medicine in which a comprehensive and precise phenotyping of the disease presentations takes place. So it includes everything: genetics, imaging, diagnostics, and signs, symptoms, etc. These methods can exhaustively examine the data with high granularity and dimensionality, and using the broad range of data types and process it for correlations, some of which may be the foundations for tomorrow's healthcare sensible evaluation. So my last thesis, since I was doing an elastography of liver in pregnancy and preeclampsia, when I read this, I instructed my resident to start collecting all the other, information on fatty liver on ultrasound findings. and of course collect data from the records on the weight, on the BMI, history of alcohol intake, liver infection, investigations like lipidogram, etc. Because now we know that AI fed algorithms can probably take out some meaningful outcomes out of this. Next slide, please. So practical utilization of AI at present has been evaluated for communications. I mean, I was surprised that about family planning methods, contraception, side effects, pregnancy, on menstruations. There are so many questions, queries by the patients, and this information was collected as to what are the requests, what are the common questions, advice, and what are the common advice given, and what are the symptoms which are reported by the patient. And all this has been fed into the computer, and this information is now being planned to use for preparing the robotic care for these communicative issues. Now, similarly, for fertility window, attempts were made to develop an algorithm that could identify the fertile window in the real time by the patient, by the patient herself. Now, in the artificial reproductive techniques, use of AI for quality of embryo and implantation success or failure has focused on morphological characteristics. There are studies on morphometric parameters and to identify differently expressed peptides or proteins in the culture media of the embryos grown by the IVF treatment, and to establish their value on biomarkers as a predictors for the health of the implanted embryo. Similarly, time-lapse images have been prepared. By time-lapse images, we mean many photographs are taken over a long period of time and then shown very quickly, as we see in many videos, a budding flower coming up. So it appears as if everything is happening very quickly. So they have been prepared, these time-lapse images have been prepared to check for the highest quality of embryo using a large collection of human embryo images. Same AI has been used a lot for the syndromic and epidemic surveillance. Next slide, please. So machine learning algorithms to predict early pregnancy loss after in utero fertilization and embryo transfer with fetal heart rate also has been attempted. So machine learning algorithm to predict these. Apart from this, there have been studies because HIE, that is hypoxia-induced and encephalopathy, has become one of the most common confronting event due to intrapartum fetal misinterpretation, litigations, and socioeconomic consequences attached to it, or on a long-term basis due to medical errors, there are complications in the neonates. So prediction models based on the phenotypes are being prepared, have been prepared, are being investigated, are being validated, and are being improvised. Similarly, we as an obstetrician, we are all aware of the likelihood ratios, multiple of the medians, and regression analysis for the models which have been constantly been prepared by many people, and Dr. Nicolaides is the leader in this as a father of fetal medicine, to prepare the models for screening of aneuploidies, which has constantly been upgraded by adding the ultrasound to biomarkers initially, and then adding more and more ultrasound markers and even biomarkers. So from this you can understand that how the AI can help us improvise what is the existent knowledge further if we continue to work on a particular issue. Next slide, please. So, I mean, I could go on and on because there are so many studies and there are at different levels. I would just, because it's not my specialty, but I would just like to conclude that AI is not a substitute for healthcare providers, but is definitely going to change the way healthcare shall be provided in future. However, to make AI an effective tool for improving healthcare system, the providers should get tuned to what AI is, how it can be used intelligently for benefit of the patient care, and acknowledge our own limitations as care providers and being simple human beings with humility, and humbly compensate for the limitations of what robotic care is in preparation for future is, by adding our TLC, that is tender love and care, in our attitude and in our prescription. Thank you. Roshni, can we end this?
Thank you very much for the very detailed account of artificial intelligence in perinatal health. You have covered a very vast area and highlighted the difficulties as well as the promises in this area. So I think it needs, and also you clearly showed when there are multiple parameters and dynamic parameters, you need large number of cases to be studied.
Yes, sir.
That is straightforward. Yeah. So people are working very hard, and I'm sure we will get some benefit of artificial intelligence and machine learning.
Yeah.
Thank you for the excellent talk.
So I just thought of talking about it. In fact, I intend to talk about it to more doctors, because our record keeping is not that efficient. But if we really want our record data to be utilized in a proper manner, we should be recording all the parameters which we think make an contribution towards the provisional diagnosis or towards prognosis or towards management.
Absolutely right. So I think the future direction is data, digital, and devices.
Yes, sir.
3Ds instead of the 3 delay model, which we used to talk about. If you can overcome the 3 delays by using digital data and devices. And
Yes,
the
sir.
fundamental is actually the data. As you say, the data, if it is not there, you can't digitalize and come out with an algorithm or something. So we had to improve on data capture.
Yes, sir.
And India is the best place to do it because
Yes,
you have.
sir. That's why, in fact, I was so keen to meet our group in at Bangalore, because I thought, we at this generation, in the generation to which we belong, we were very clinically more sound than ever. Somehow we were very dependent on our clinical findings, but this may not be that much required in future, provided, but the learning, we should be able to use that for our AI data.
Yeah, I think you're right. I mean, I think you can service more number of women
Yes.
by developing AI and machine learning. Like you showed the first trimester scanning, for example.
Yes, sir.
For scanners cover a large number of women. So if you have AI substituting for
Yes.
others, then it might help. So it not only it's a really better service, but also for more women, we can provide the service by developing AI and machine learning. Thank you. So we'll go to Dr. Sheela Mane's talk, and then we'll open it up for questions and answers from the audience.
Excellent talk, Dr. Alka.
Thank
And
you.
thank you, thank you. So much of thought-provoking, but I always feel, that we lack in human resources, unless and until we have enough human resource, and particularly in institutions, in public sector, the government wants, now we have started entering the data, but the workload is so much, and there
Yes, sir. Yes.
are no people who can really act. So what I feel, unless and until there is a human resource who is properly trained, we can really generate, we can create wonders if we really collect the data. But I hope that one day, the day comes that where we are able to do that, and it will be really, really very helpful.
Actually, there is
your
a need
presentation
for
was very good, and you have already
in fact, I'm sorry I could not present it myself, because and when made my slides very crowded, because otherwise by animation only part of it would be visible, rest of it would disappear. So but that animation somehow I think could not be transferred on mail to.
we will invite you to Bangalore.
Yeah, I think I was just thinking that I will collect some topics on which we can probably discuss, have some discussions there, And together we can probably think of some ways, because what is the need is the need. So the need is of integration of, doctors as well as people from other fields. We don't know much about their fields. They don't know much about our fields. So there is a need for that integration actually.
Okay, Sheela, all yours now.
Thank you.
Yeah.
Yeah, can I proceed? Yeah, yeah,
Yes.
fine, thank you. I think the screen is visible. Yeah,
Yes.
thank you. So, my talk today is on prolonged deceleration and sinusoidal pattern. And now we come to the practical thing, I think. So, the slides are not moving.
And make it a
So there is a case. I will directly go to the case scenario. Yes, sir.
You can make it into full
Am
screen.
I audible?
Yeah, you're audible, but we can
Oh,
make
yeah.
it into
Yeah.
full screen.
Yes, sir. Yeah.
Thank
So
you.
there is a primary term pregnancy, spontaneous labor, and she is almost 3 centimeter dilatation and clear liquor is draining. And this is her, we can say, on admission, the trace is
Sheila, we can't hear you. It's frozen. I wonder whether you can switch off your video and still the presentation will come through, because we can't hear you.
some disturbance, sorry.
Yeah. Come back to share screening.
Yeah, sorry. I'll have to go back, I think. Do I have to share it again?
Yes.
Yeah, some disturbance in the internet. Yeah, sorry. Yeah. So here we can see that there are decelerations coming up. The first trace here, and again the second trace, we can see that there are almost, we can see that there are 3 decelerations there. And this was there. The next, again we see that there is an increase in the decels here. So now I would like to know, sir, that if we get these type of picture, and she is getting good contractions, so what do we do now? Suppose if we have this type of scenario.
Well, is she on oxytocin?
No, she's not on oxytocin. She's spontaneously, she's progressing.
She is, I didn't remember the parity and the cervical dilatation at this stage.
Primary, she started with 3 centimeters dilatation, and then we have to think about it that we have to change the maternal position, but there's no hypotension as such.
Yeah, we had to hydrate, put on the side, but the baseline rate hasn't started going up yet. So we can, depending on the cervical dilatation, you can observe for a while.
You're not audible.
So this was the picture. Really giving me trouble. Sometimes the things are not in our hands. Again and again, I have to share.
Yeah, the bandwidth will not be adequate, Sheila. So you can use the slide sharing, but I don't know
Yeah, I have
whether-
already shared. I have already shared with them, but I thought I will share so that I will be able to.
Yeah, you carry on.
I'm really sorry about that. Otherwise, I can ask them to share and then I can proceed. That also I can do. So now she is 9 centimeters dilated and vertex is at -1 station to 0, we can say, on vaginal examination. But she has progressed well.
Good.
Yeah, and now other interventions, whether we have to think of, again, we have to assess the maternal vital signs and again repeat the examination. And there is a spoiled mnemonic, that is if she's on oxytocin to stop left lateral position. And I don't think she requires any oxygen here. IV fluid bolus if she's dehydrated. And if there is a low blood pressure, we consider vasopressin or ephedrine and tocolysis if there is a need, or we discontinue the oxytocin. And I think everything should appear within 30 minutes. So oxytocin, again, we have to think whether it is a bane or boon. So reducing or discontinuing an oxytocin infusion. And it is found that after oxytocin infusion stopped after 15 minutes, there is a 22% reduction in uterine activity, 30 minutes, 39% reduction, and 45 minutes, there is a 48% reduction in uterine activity. But it all depends on the dilatation, whether we allow her to go ahead, and the status of hypoxia of the fetus. Now, tocolysis, yes, if we know that there is a requirement, then more rapid reduction in uterine activity, and we can give terbinafine. It's given subcute, and there is a rapid onset of action with a reduction in uterine activity of up to almost 87% in 15 minutes. But we'll have to think of alternatives also, because it all depends. The resolution of tachysystole intervention, suppose if we discontinue oxytocin, resolution will take 14 minutes. Oxytocin discontinuation plus IV fluid bolus, at least 500 ml, then it takes 9 to 10 minutes. And oxytocin discontinuation plus IV fluid bolus of at least 500 ml plus change to lateral position, it takes 6 minutes. So these are the things like where we do some interventions can change the scenario. Now, how the lateral tilt can increase the cardiac output by 20 to 25%, stroke volume by 25 to 30%, and can decrease the heart rate by 5 to 6 beats per minute. So if the patient is in supine position, left lateral tilt can also help. Coming to the fluids, a fluid bolus of 500 to 1000 ml, lactated ringle solution IV over 20 minutes. Or a glucose-containing IV fluid should not be used, we know that. And thought to improve uteroplacental perfusion through expansion of maternal intravascular volume. And positive effects can continue for about 30 minutes.
The volume is frozen, Sheela.
Go back. Sorry, but I will again do it. I'm really sorry. So FHR less than 80 beats per minute, more than 3 minutes, and pH drops by 0.01. Now we know that there is a chemoreceptor stimulation, vagal stimulation, FHR decreases. And sustained insult can cause myocardial ischemia, and further there is increase in FHR. And these conditions are usually cord compression, abruption, uterine rupture, and uterine hypertonicity. And it is very disheartening, particularly, with cord prolapse and abruption, because we would have recorded the FHS and suddenly we find that there is a bradycardia, but this happens with incidents. Now, intrauterine resuscitation, whether there is a need for intrauterine, again, up to 40% of instrumental deliveries are performed for fetal distress, and 30% of cesarean deliveries are performed for a combination of failure to progress with fetal distress. So the aims are labor can be safely continued. We have to improve the vaginal delivery rates. Fetal well-being can be improved prior to emergency delivery and avoidance of general anesthesia. I think these are all the overall, when we think of that there are decels, whether it is the hypoxia is progressing or there is an acute event. Now, coming to the guidance on management, 3 minutes, if the prolonged deceleration is abnormal, we can still review the clinical circumstances. But if it goes on for 6 minutes, then again, whatever we discussed so far, we can try. There could be 90% recovery if no pathology. So we will have to keep everything ready for category 1 cesarean. 9 minutes, 95% should show signs of recovery, but we have to move to theater. And 12 minutes, if we still find that it is persisting, definitely I think we have to commence the anesthetic procedure if no recovery, and wait in theater, again observe. Okay, for 15 minutes, I think is the maximum where we will have to go either for LSCS or assisted vaginal delivery. But we again think, when we are counting like this, whether it is realistic. Just now, madam said that 95% went for cesarean. So unless and until we know how to predict and how to assess, I think we'll have to really think whether it is realistic. So this was the trace, and the patient delivered as she was 9 centimeter by venous assisted with episiotomy. The baby was 2.8 kgs, good UPGARs, and cord gases were also normal. So would like to hear from you, sir, that in these scenarios, here the patient was progressing well, she was dilated, so we could deliver her vagina.
Yeah, I think there was no increase in baseline rate significantly, and the baseline variability was maintained.
Yeah.
So those are good reassuring signs. And obviously it's done at the right time, because the latter part, the last 3 centimeter segment shows its tendency to heart rate to come down a little bit more. But the previous 10 minutes, there is more time spent at the baseline with good variability. So it's concerning, but not that great significance if she's going to deliver quickly.
Okay, sir. Thank you. So, yeah, I think the viewers can also see that's a very good point which sir has pointed out, that the baseline variability is maintained, and there is some hope that the baby is not severely hypoxic. And if the patient is progressing, we can assist and deliver the baby faster. So this is just one slide to show that how to do the cord blood gases. We have to double clamp about 10 to 20 centimeters of cord. Stable in room temperature for 20 minutes, and we should have a syringe on ice for 30 to 60 minutes. And then we'll have to note that the vein is in the middle and the artery is up. So, and see that there is no air in the sample, adequate heparin is there, and then proper technique should be performed, should be practiced, and for the interpretation, because that is very important. So the training is also equally important when we are planning to do this. So umbilical cord blood gases, effective risk management tool to document the absence of any significant metabolic acidemia in the immediate newborn period. Most objective determinant of fetal metabolic acidosis at birth. Paired sample essential. Arterial pH is less than the venous pH, and the difference is the AV difference should be more than 0.02 pH units. And for CO2, PCO2, the AV difference should be more than 0.5 kPa. that is 3.75 millimeters of mercury. I think nowadays in private, some corporate hospitals, we have started doing this umbilical cord blood gases. And suppose if you want to assess the neonatal signs of perinatal asphyxia, then yes, firstly we look at the Apgars, less than 5 at 5 and 10 minutes of life. Umbilical arterial cord gas less than 7, and or base a deficit of more than 12 millimole per liter. Neuroimaging, I think, are coming up, but definitely not available. Deep nuclear gray matter or watershed cortical injury, organ dysfunction, and CP, that is spastic quadriplegic or dyskinetic type. So metabolic acidosis in umbilical artery blood or in newborn circulation during the first minutes of life where the pH is less than 7 and base deficit of more than 12 millimole or lactate more than 10 millimole is proven of a metabolic acidosis. There, yes, a low Apgar scores, early onset hypoxia, there could even the ischemic encephalopathy grade 2 or 3 can happen. Early imaging studies suggest you of an acute and non-focal cerebral anomaly, spastic quadriplegic or dyskinetic types of cerebral palsy, and exclusion of other identifiable etiologies such as birth trauma, coagulation disorders, infection, and genetic disorders. But currently, I must say that in major hospitals, public sector, we don't have all these facilities. So this was the neonatal encephalopathy and cerebral palsy study by Task Force 2003. And epidemiological studies suggest that in about 90% of cases of cerebral palsy, intrapartum hypoxia could not be the cause. And in remaining 10%, intrapartum signs compatible with damaging hypoxia may have had antenatal or intrapartum.
Sheila, it's frozen again.
I think she's struggling with her computer today. Technology can be.
I know, actually, I have tried the another link now, but still it is troubling me. I'm using the hotspot, but still it is giving me trouble.
Okay.
So, yeah, documentation and think of reversible and irreversible causes on examination, importance of intrauterine resuscitation, that is again that spoiled whatever we thought of position changing, oxytocin to be discontinued, and all those things. And the 3, 6, 9, 12, and 15 minutes guidance for acute hypoxia. Sir, I would like to hear from you about this, that 3, 6, 9, 12, and 15 minutes. And again, that maternal heart rate. So I had a doubt whether that first trace, which was showing so much, whether it was combined with maternal heart rate.
Now, there were segments of maternal heart rate in the latter part of the trace, which was coming higher up.
Yeah.
Most of it was fetal because with head compression, with the head going down, there should be deceleration. So that trace is a little bit mixed with maternal heart rate, but predominantly it's the fetal heart rate tracing you showed.
Okay.
In terms of the 3, 6, 9, 12 minutes, the first study which was recommending that was from Singapore when we did it in 1985, because the drop of pH was 0.01 every minute when the fetal heart rate was less than 80 beats per minute. And 25 years later, the same study was repeated in the University of Hong Kong by Tiva Leung, who also showed the same drop in pH. So if it shows signs of recovery, the heart rate starts coming up, then you can wait. But if it is still going down below 80, then you have to follow these 3, 6, 9, 12, 15 minutes. It is not called as a rule, it's given as a guidance because not all the hospitals might be able to do that. And the Singapore as well as Hong Kong, they have timed it, and most of the bigger units are able to do it within a very short time because the staff is already in the labor room. But in smaller hospitals and smaller units, they might find it more difficult. But naturally, the incidence of such things happening will be less of a problem in those hospitals.
Yeah, because by the time we reach the OT, we take the decision that itself will take 15 minutes for us. I mean, once we take the decision, so this monitoring, we have to see. I know we should have a OT which is just next to the labor room where we will be able to shift the patient and operate fast. So this was another case, again, primary with gestational diabetes mellitus on insulin. Induction of labor was planned at 38 weeks. And she was the Foley was used with meso, and the patient had some contractions, but the first trace itself is showing that there are some decels here on this trace, and then again the next trace also showed, and it's quite prolonged. Even the after a few minutes only it is picked up, and this already we discussed, but with this type also, I think we can definitely try because it's not coming very frequently, but it is prolonged. And I know we already discussed these things about positioning and whether any sympathomimetic drug administration happened, and that can lead to prolonged deceleration. So we will have to relieve hypotension. So then oxygen administration for FHR abnormality, like if there is a minimal variability, late decelerations can promote oxygenation. Amnio infusion, if there are recurrent variable deceleration, which can elevate the cord compression, and again decrease and discontinue oxytocin and administer tocolytics, which can again decrease contractions, and tachysystole with category 2 and 3 tracing. And cervical examination again can cause, if there is a bradycardia, prolonged deceleration. Particularly, we will have to identify the cord prolapse. So this was dropped more than 50 beats heart rate, and this was again the picture here. So the outcome was naturally it was coming like this, and this was the pH was checked, which was 7.3. Outcome, yes, the patient had LSCS baby 2.5 kg male, good upcars, and cord gases were also good. So these type of cases, so do you think that we should wait, or we can, because the pH was 7.3 and
the baby is on the small side, 2.5 for
yes,
term pregnancy. So naturally, there's some element of growth restriction.
yes,
And some element of oligohydramnios, which cause temporary cord compression. But if it is isolated, if prolonged deceleration, then we can wait and see. But the only issue is the induction with misoprostol can give rise to hypersystole.
yes.
So if there's no other facilities, then you have to depend on Foley's balloon followed by oxytocin infusion, which is more easier to get regular contractions compared to misoprostol.
Than misoprostol. We have seen tachysystole with misoprostol, and most of the time even meconium stain like it.
Yeah.
Yes, sir. Thank you. So when a CTG is reviewed, again, we should have a look at the complete picture: meconium, oxytocin, temperature, hyperstimulation, hemorrhage, same epidural, rate of progress, and if there is a scar. And we'll have to be aware of bleeding or significant meconium. So this was another case where she was a primary, uncomplicated pregnancy, 26-year-old, 40 weeks normal growth, AFI was only 4, and induction of labor was planned. Again, misoprostol was used, contractions were commenced, and at 1:30 p.m., she was 3 centimeters dilated, cervix was 0.5 centimeter long, and ARM liquor was clear. And here, 1:30 p.m., the syntocinon was commenced and epidural was cited, and this was the trace. which is quite satisfactory. And then later on, this was the picture. Like we found that there are repeated decels, and further again after a few minutes, it was the heart rate was going still below. The position change was done when still deepening was seen, or the bradycardia was seen. And then at 4:20 p.m., the trace was like this, where it was still in a normal range only, and the bit-to-bit variability was also good. And then she was 4 centimeters dilated. And here I think the probe was not placed properly, or could be, so that is why it looks like artifact. So it is difficult to comment about that. And whether there are chances that again, whether the maternal is picked up there, because the probe was not placed properly otherwise. And the PV finding was she was 4 centimeters dilated and -1 station and fully effaced at 5 p.m. And at 6:20 p.m. again, it was okay. I mean, the bit-to-bit variability was good. In between there was, but again it was picked up. Okay, it was picked up all the time whenever there was a dip. And at 7:20 p.m., this was the trace, which is again showing tachycardia as well as sudden bradycardia. And she was fully dilated, but here, and it was a +1 station. So this was a active second stage, almost she was fully dilated, and she delivered by venous delivery. And again, the cord gases were arterial was 7.2 and venous was 7.3. And so, sir, this second stage, sometimes we do find that there is bradycardia. So could it be, I mean, she was well progressing, so we could wait. So what is your remarks?
Yeah, we could wait. The only thing is the contractions are far too many, because the second stage, the Ferguson reflex also kicks in, reflex release of oxytocin. So if she was on oxytocin, best thing would have been to stop. The delivery would have happened, but a little bit later. The fetal condition will not be compromised. But if you are not on oxytocin, then we had to think of doing an instrumental delivery. So if depending on, you can see the contractions are from time to time.
Contractions are very frequent. Yeah. So oxytocin always better, because once we have given misoprostol, we can't go back. I mean, the patient would have started getting, but luckily she progressed. And yes, sir.
Yeah, that's correct. Oxytocin is much safer, and you can stop it, and the contraction, if it reduces, then the trace will.
So yeah, this was another case where we see a sinusoidal pattern. Now, sinusoidal pattern can be physiological, where it could be due to sucking the thumb or smacking lips. Even analgesia administration, it can happen. And seen with chronic fetal anemia with erythroblastosis fetalis from RS sensitization, parvovirus or alpha thalassemia. And could be acute intrapartum asphyxia, feto-maternal hemorrhage, and vasa previa. So this was a gravida 2 with living child 1 with 35 weeks plus 3 days. And she was an AOI reversal and third centile. And this was the trace. She was 3 centimeters, but she was getting very good contractions. Again, the bit-to-bit variability is good, but it is a saltatory pattern. Sir, any comment from your side?
No, the normal baseline, the variability is good, and there's a tendency for accelerations. And there are no definitive big decelerations with the contraction. So best thing is to continue.
So this was the further tracing again, where, but it was again picked up. The bit-to-bit variability is good. The baseline for some time, few minutes, it was not maintained. Otherwise, it is maintained. And again, when their contractions are strong, I think we can see that there is a little drop. But again, it is picked up after the contraction is over. And with further contractions, again, it is better. So here again, we see that with the contractions, again, there is a dip, but again, it is picked up again. So here again, the pervaginal examination was done, and she was 2 to 3 centimeters dilated. And but we see this type of pattern again. And here, this was post-epidural, where we still find that the cervix is thick, but the dilatation is about 6 centimeters, and the vertex is at -1 station. And the pulse rate is around 108, and this was post-epidural. So can we, I mean, post-epidural also, we can get this type of trace, sir? I mean, your comment.
For a short time, you can get a little bit saltatory or atypical sinusoidal. That should settle within 25 minutes. Because when they bend the woman and there's a uterine vessel compression, when the head goes down a little bit, you can get a slight hypoxia, which the baby responds with an exaggerated variability. So that's okay. In 6 centimeters, you can continue.
Okay. So I think, yes, as you said, it was, again, I think satisfactory. And then she delivered. It was a small baby, 1.86, and it was only 35 weeks. And the cord blood gases were also okay. So this was one monochorionic diamniotic twins, where 36 weeks special labor. And the first, again, we see the sinusoidal pattern, and that was the baby who was anemic one, and the other one is the with polycythemia. So this was again a spontaneous labor. So with the anemic baby, it is seen that more of a saltatory type of pattern and sinusoidal, and the lower one is the other baby. So that was because of that. And this was again primary at 40 weeks with spontaneous rupture with induction of labor, in labor at 3 centimeters. And if we get this type of trace, I think again it is very confusing. So what should we do? Your comments, sir?
You can wait and see, because the so-called baseline is the previous baseline. So the going up is not something to be concerned about. With some, it'll settle down after some time. I'm frozen again, Sheela. We have 10 more minutes to go.
Are the contractions not too frequent in this case?
Yeah, a little bit more frequent. It seems to be slightly incoordinate contractions as well.
Yeah.
That's what I was thinking, that I was happy that it's not troubling me, but again it started.
So Janitri might want to see whether we have 10 more minutes, whether there are any questions for Sheela. Or...
Yeah. I think we can do that, because I think I'm almost done.
Okay.
Yeah.
No, we don't have any questions right now, but there's one mother who asked that when the baby is born, when her baby was born, the placenta was black. It is usually transparent. So she just want to know what would be the cause.
I didn't get the question. The baby was born?
So the baby is born, but the placenta is black. It is usually transparent. What would be the cause?
Well,
Placenta is black. You mean color?
Yes.
But was there a retroplacental collection or abruption? In that cases, we might find that color discoloration of the maternal side of the placenta.
Still, it would not be black. It would
Anything,
be more
Alka?
like dark blood.
it'll be like a buffy colored, like a flesh.
Yeah.
That's the situation of the placenta. And beyond the placental margin, the membranes will be transparent.
Yeah.
Any other questions or queries?
No.
Okay, so if Janitri wants to sum it up, then we are happy to listen.
Yeah, if there is nothing else, then we can sum it up right now.
Okay, so that's no comments from Janitri. I thought on the program.
Dr. Alka, Dr. Alka.
I think we're done with today. We can think of, are we going to have, I was just wanting to know, are we going to have all classes revolving around the fetal heart monitoring only, or something else is also in mind from the Janitri team? But anyway, this can be discussed on WhatsApp later on.
Okay.
Yes, we will have one more session on fetal surveillance and you will get to know about the details.
Okay. Okay.
Okay. Thank you, sir. It was a
Thank you very much. We have to thank
Yeah.
Professor
too much insight.
Alka and Sheela Mane, and also the organizers, Preeti
Yes, Janitri.
Yeah.
Thank you
and
so much, Doctor, for taking out time and for this session. Thank you so much for this informative session.
Thank you.
weekend, and goodbye.